I'm Matthew. This is the Kind Podcast, and today I am here with
Jenny Bartlett Prescott.
beautiful. Welcome, welcome. We are excited to have you. Excited to talk. Before we dive into the world of what you do and all the people that you serve, I'd love to just talk about your background. So, where'd you grow up?
I grew up in Decatur, Georgia, which is like a little tiny town that's embedded into the eastern side of Atlanta.
Oh, okay.
Yeah.
Georgia. What about your upbringing do you think kind of led you towards the pathway of what you currently do?
I really credit my mom and then her father, my grandfather on that side. Social justice has been a thread throughout that family story in particular. My grandfather was a Disciples of Christ minister during the civil rights movement in Ohio and was involved in the civil rights marches, came down to Mississippi, arrested, knowing he would lose his job. And he was the sole provider of his family. And I just have always admired the personal risk he took to stand up for something that he felt called to speak to be a part of, not knowing what the outcome would be. And so I've always kind of questioned, would I have that same level of guts? But from that, my mom did a lot of advocacy. I grew up going to marches, and then she actually started coffee houses in Atlanta that raised money for a kind of global social justice organization called the Unitarian Universalist Service Committee. So, anyways, it was just part of the DNA, literally, and I've always felt something joyful, I guess, when serving others and speaking up or being part of making our corner of the world better. From the time I was little through college, and then figuring out how to do that as a career.
Yeah, I mean that you're literally made for the job that you do. That's beautiful. When you're growing up and you're seeing these different, you said like you're going on marches and you're seeing your grandfather, kind of go out and risk a lot for personal gain. Do you look back now and kind of see a resemblance of what you currently do, and is it something that you always look to kind of strive for as you continue on your path in your career?
Um, it's that saying, be a part of the change you want to see in the world. And I think that's truly what all of that kind of ingrained in me. And that's more the connection. Do I feel like I have risked as much as maybe my grandfather did? No, I don't. But, I'm really proud of that and feel like it's part of my story in some way or another and connects to what I'm doing and who I want to be, who I want my children to be.
Absolutely. And so, before we get into the current work you're doing, can you kind of talk us through? I guess we could start at graduating high school. Like, what has been the pathway to lead you to where you're at now?
So, graduating high school, I actually came to Memphis to go to Rhodes College, and I was a biology major. And all of my friends, my posse from college, are doctors and all of that. And I think the assumption was that I would do that myself, but I am too impatient. It takes too long to actually be able to start working as a physician. And you also have to take physics, which was not my desire either. And like I said, my leading energy was around social justice more than any particular profession. And so I kind of went where the wind took me. And Dr. Scott Morris, who's the founder of Church Health, came and spoke to a senior career event. I got to introduce him, and he offered me a job after that event. Turns out that one of his best friends was my advisor, and I didn't know that. But I'd done an internship at MIFA, and way back then, 1997, service learning and that idea of engaging in community service work to work alongside these academic theories you're learning was new to the scene. And so I was one of the first service learning interns at Rhodes, and just really saw how, the work we do in our communities. And in like my senior year, I built an assets-based map instead of a problem-based map of this community that Church Health happened to be in. So it all kind of forecasted, this is where I'm going to be. And then a few years into it, I got a master's in epidemiology when I was at Church Health. You know, it's hard, and if you want to be involved in the nonprofit world, what are you going to specialize in? What's my technical skill set? I'm managing people, and again, way back then, I feel old saying it, but program evaluation and the importance of nonprofits being able to articulate impact with data was new. And so we did not have a School of Public Health at the time, but we did have the School of Preventive Medicine through UTHSC. And so that's where I got my master's in epidemiology, really in an effort to be able to specialize in program evaluation techniques and abilities. And it, fast forward 20 years, it came in very handy during the pandemic, but that wasn't the root reason, at least, for getting an epidemiology degree.
Right. Wow. Biology, that is really interesting how that ties into what you do now. I would have, I found myself in a similar boat. Like I did psychology as my undergraduate, and then I graduated, found out that like with psychology or like mental health services, you kind of got to specialize in something for your degree to really propel you into a career. And that's when I found social work and, ended up where I'm at now. But it's so interesting to me the amount of different backgrounds individuals have that end up in this field. Especially when like the higher levels, like the CFO, COOs, like you would imagine this has been their goal the entire time. They had this planned out, but it really is like people find themselves wanting to help. They figure out how they can do so. So that's a beautiful path. And
Let's take the next step. And we've got a lot of young people that are with us in a gap year program, and that's usually the advice I give them is, I did not forecast working in the same organization my whole career. I was fortunate to arrive when we were growing, and so there was kind of a next thing for me to do. But yeah, you just take the next step in front of you and make sure you're doing something you actually enjoy doing,
Yeah, my dad always said, if you love what you do, you don't work a day in your life. So I try to live that mantra a lot. And so for the folks that don't know, what is Church Health? What are the services that are provided? Kind of what's your role within that company?
Yeah, so Church Health is a faith-based charitable clinic. It started back in 1987, and we primarily are serving the people in our community who have low-wage jobs, don't have access to health insurance. Over the years, as healthcare has expanded and changed, we've extended that to be their family members as well, or as they age into Medicare, we'll continue to be their provider. But for the most part, we're serving the working uninsured and their families. And then we've expanded. Healthcare is not just seeing the physician, and so we've got dental and eye and physical therapy and nutrition and behavioral health and all of these aspects that make up health, along with wellness services like cooking, a partnership with the YMCA for movement, and really trying to be able to be a place where people can bring their whole lives when they come to the doctor. Coming to the doctor is usually the reason they walk in our door. Yeah. But our lives are complicated, and we cannot segment them out into these individual, topics of conversation. Our work life, our family life impacts how well our blood pressure is controlled. And so, again, trying to create a model where we can talk about all those things with our patients and hopefully create a plan with them that helps address that whole context of their life. My role there now is Chief Operating Officer, which is where all the clinics and programs that we do report up to me. And I often joke that my real job is to herd the cats and keep the frogs in the wheelbarrow. But I love what I do, mainly because, I get to show up every day knowing we're changing people's lives, making a difference in our corner of the world. And we've just got an amazing team of people I get to work with every day.
Yeah, that's beautiful. And I love what you mentioned about there's a lot more to health than just seeing the doctor. I think that is kind of a newer age thought that, obviously throughout the years you learn more about the human psyche and like what goes into health and how everything interplays. But the fact that you've been able, or the entire company's been able to shift with that has been really huge, because it's true. A lot of people don't realize that daily interactions, family relationships, what you have access to, all of that comes together to culminate your health. It's not just you have bad blood pressure, you got to go see someone. There's reasons behind that. There's reasons why it's occurring. Um, and so with everything that y'all are doing, kind of like in your view, what's the current status of healthcare when it comes to vulnerable communities?
That is a good question. It's a complicated question. It's hard to answer quickly, but I will at least speak to what's top of my mind. And I think it's something that's shifted a little bit recently. And one of those things is just how we define what does access to healthcare mean. Certainly, vulnerable communities, folks who live in areas that maybe aren't safe or healthy housing or lack of quality education or all of those things, right? The social determinants that we talk about of health, those impact the ability to have a healthy community and goes without saying. But when we talk about just access to healthcare, right? Back in the 80s, it was like the assumption was as long as you had access to an emergency room, that was good enough, right? And that is truly where we have universal healthcare. Everyone can walk into an emergency room, and if they are having an emergent condition, they will be able to get treatment, regardless of insurance status, documentation status, anything, right? And over the years, and the ACA was passed, and that conversation shifted to access to quality care, and then we start to talk about primary care and subspecialty care and what you need to actually avoid ever having to go to the emergency room at all. And so the conversation around healthcare was more about cost and efficiency and all of that. Well, now it's reversed, and we're back to true access to care that we define in our country as often like baseline emergency room access. And so it definitely feels like we've backtracked some. I think when we're in roles like Church Health is in serving our community who doesn't have access to insurance, it is up to us to lift up the stories of how that kind of system impacts the people we see and who's falling through the cracks. Healthcare is a complicated system. One thing I learned during the pandemic when I was working with leaders of all different kinds of backgrounds is many people just don't understand how it works and how the funding works and where people fall through. Many people felt like the Affordable Care Act solved the uninsured problem in our community, and it just hasn't. Our system is built on an assumption that if you're too young to work, you have access to Medicaid. If you're disabled and you're not able to physically work, you have access to Medicaid. If you're too old to work, you have access to Medicare. Everything in between, you're working and your employer offers insurance. That's just not the truth. So I think that is, when we talk about system change and long-term change related to healthcare access, that's something we're going to have to grapple with as a country is why don't employers offer it? And we all know the reason is because it's too expensive. And so why is it too expensive? And just continue to try to get to the root causes and look for examples around the world where it's done a bit better. So
Absolutely. Yeah, and I think you hit the nail on the head with it being complicated. Like we were talking before we started, like I'm diving into the world, and I was telling John, because we were talking about scheduling something else, and I was like, dude, to be honest with you, this IOP insurance stuff, every time I feel like I have reached a little mountaintop, I find that I have to verify 50 more things and then do a whole set of other things just to be able to qualify. And
it makes it hard.
it does.
It makes it hard for the providers to be able to provide the care, and frankly, pulls people away from why they went into healthcare in the first place when they're having to deal with all that administrative burden.
Absolutely. Yeah. I think that's one of the misconceptions is it's some people think it's like a lot of providers just like not wanting to provide work no, it's really the amount of hoops you have to cross over and the amount of things you have to do just to be able to get like a baseline understanding of how you can begin to provide. And then when you start to provide, then you have to do all these different specialty things and all the different requirements. And I think it's a lot more tedious and a lot more I would say, difficult than I imagined it would be. So it's opened my eyes on that end of things. But to that level, like, what are some other misconceptions that you think maybe people have or the community have about the work that y'all do, or kind of like why it's needed to begin with?
Yeah, I mean, I'm not sure, if there's necessarily misconceptions other than just really understanding who's falling through the cracks. And, I think it is hard for people who maybe have never had to experience being uninsured, that you can have people working full-time jobs doing everything they know to do and still not have access to affordable insurance. And then what does that actually mean? And one of the stories that was told to me not too long ago, and I just keep repeating it because I just can't believe we live in a country where this is possible. But if you are uninsured and you have some sort of brain bleed or situation where the emergent solution is to remove part of your skull to relieve the pressure, that that is taken care of, and you can apply for charity pathways so that if you can prove your income, all that can be written off. But once that emergent situation is passed and you need that skull repaired so that you don't have a hole in your head anymore, there's no pathway to get that done. So we have several patients who are in that situation. They have to wear a helmet all the time. We have no way to get that skull repair done because it is no longer an emergent situation. And that's what I mean by this when we talk about access to healthcare is just ER access. That doesn't include any of the follow-up care. And so we have people falling through the cracks, even just through that ER access system that supposedly is in place. You would not think that the United States would be a country where people would walk around with holes in their head.
But question, the growing cost of everything, and you look at, like if your parents get their, you have children, it's usually, isn't it, the, when you're the parent, your insurance kind of trickles down to your child, for childcare, things like that. Is that how that works?
So the ironic thing is that when people are in lower income brackets, it's not uncommon where within that family you have multiple different types of insurance. You don't just have one insurance for that family. You may have a grandmother on Medicare. You may have a mom who's on TennCare temporarily because she is pregnant, and the children can be on TennCare. What you're maybe speaking to is one of the changes related to the Affordable Care Act is that children can stay on their parents' plan until the age of 26. But that's only if your parent has insurance.
If they, yeah.
If your parent has insurance, yeah.
What if, how does that impact like childbirth or getting pregnant, taking care of the cost of all of that? So, things that I'm really thinking about, does that, does the cost of that, if you don't have insurance, does that become a sunk cost that follows you around? You have to cover some kind of way if you don't have insurance.
Yeah, I mean, Tennessee has presumptive eligibility if you're pregnant so that we can get people on TennCare if they're pregnant. Now there are income requirements and things, but usually we're able to get the women on that, and it will then cover the childbirth costs. But again, there's a lot of hidden costs that it doesn't cover. Childcare is a whole other thing that, of course, isn't involved in healthcare.
Yeah, that falls under like the social determinant part. It's like one of those things where it's not directly your health, but it does directly affect your health, and it also affects your ability to become eligible. Because if you have to take care of children all day, how are you expected to then work 8 to 12 hours and then meet the requirements that they have? And I think that's where we find ourselves a lot. Like, we have the whole family campus opening up and things like that. And it's like one of the major issues we see is childcare. And like that, it's one of those things that people don't think about with that specific population, because there's always that assumption where you said earlier, there's like that whole middle ground of people where you're not too old, you're not too young, and you have the ability to work. So why are we not working? Right. And it's like there's so many different mitigating factors that can cause an individual not to be able to work that aren't quote unquote disabilities, but they are things that have to be taken care of to be able to freely go out and obtain that income. And so that that story about the skull just like threw me for a loop. That is how would that not be an assumed covered cost that when I remove this thing from your body, I'll be having to put it back on, or I'll be having to put in a filler, or have to, suture it up, something. I mean, that is
It happens in other specialties too, where, maybe whichever specialist is on call for that ER visit takes care of whatever that emergent surgery is, but the follow-up care doesn't happen in the ED. And if they work at an office that doesn't have a charitable pathway, you don't have a way to get the follow-up care because no other specialist will see you for care that somebody else delivered. So you can get stuck even for follow up for, a orthopedic surgery or a urology procedure that was an emergency, but you don't have access to follow up care. So we get those patients to us, and our providers do the best we can do in a primary care setting. And then we spend a lot of time advocating. I think when you talk about misconceptions, one of the things that I've really appreciated being in my role at Church Health is getting to actually meet all the leaders in our healthcare systems, in all the different systems. The systems don't always get along, but the leaders in every single one of our system are good people, right? They want the best for Memphis and often have an impossible situation when it comes to all of the different demands on the hospital systems. How the funding flows can really complicate things, and just trying to be able to meet all the needs of all the stakeholders and also provide the care for a community that has an incredible amount of need. And you find it's not uncommon where people say, oh, this thing worked great in Boston or Houston or whatever, and let's bring it to Memphis. But Memphis has a different level of need than a lot of those other communities do. And we just have to be aware that just the level of people who will need that service, and for it to be sustainable in our community, it needs to be able to hold up against that level of need that we have here compared to other major cities.
absolutely, yeah. A lot of like the conversations I have around the work that I do, especially with like friends, family, or just people that are in different sectors of work, is we're in like one of those spaces where there is no such thing as a cookie cutter solution in social work or in healthcare, because there's never one size fits all. And you have to create specialty, either circumstances or resources for all these different individuals, because everyone's coming to you with a different need. Not to mention you're working with an individual at the end of the day, like that is a human being in front of you. And so any solution you provide to them needs to be tailored to whatever specific need they may have. And I think it's kind of one of those things that gets kind of caught up in the minutia of healthcare, and like, oh, we have this great thing and it covers all this stuff. And then, like you said, when you get down to the reality of like post emergency room visit, there's so many other things that pop up. And so I think it's wild.
So just for minutes talking about there, like, does that give you anxiety about the need for tailored solutions to the individual or the healthcare industry in general? Is that, because it sounds like it's a big headed bill to do something like that as far as time, resources, and things like that. Tailored, customized approaches to.
Yeah, it is. And I mean, if our primary care physicians were here, they would tell you that is, I think, one of the biggest challenges in their profession is we have a system, right, of healthcare that expects to be able to break up office visits into 15-minute chunks. And to do a tailored solution or to address more than just that main need that brought them in front of you in 15 minutes or less can be impossible. And so, we often say at Church Health, we have to hold ourselves accountable to kind of what the industry standards are, right? We're going to be judged by the industry standards, even if we disagree with why those are industry standards. So it's like we have to try to fix this broken car while we're driving it down the highway. How do we do this better and also still meet the industry standards while we're still doing it better? And so some of our strategies with that have been to really lean into what we call extender roles. Physicians can only do so much, but we have behavioral health consultants in clinic, we have dietitians, social workers, health coaches. What can our nurses do? What can our medical assistants do? So that we are truly, I say healthcare is a team sport, and I mean it. Like we have a team that is going to work with this patient, and it's not just all on the physician. They don't have enough time, and they don't have enough training to do everything. And so that is one of the strategies we use, and we've really been using for many, many years. Thankfully, healthcare is starting to reimburse for some of that. You're starting to see the Medicare and Medicaid plans begin to pay for things like navigation or health coaching. It's been an interesting journey as this kind of value-based care moves through healthcare without necessarily the payment models that support some of the initiatives that would happen outside of just the medical realm, but that we know impacts our patients' lives. I remember going to a conference a long time ago, and this medical director of some clinic got up there and just said, listen, if you want to be a physician that actually has control over your patients' lives, you need to work in the ICU. That is the only place. And it's a act of humility to be a physician in a primary care setting, because you may see a patient 15, 20 minutes 4 times a year. Think of all the other forces at play in their life outside of your time with that patient. And so we have to engage with that, right? We have to engage in the reality of the context of their lives and not just assume that we can write out a plan, give it to them, and they're going to be able to follow it. And so, we try to make sure that we're doing that we're also thinking about our healthcare delivery system as something that happens over time and is not just this episodic visit to visit, but how are we staying connected? How are we part of that longitudinal visit with the patients? And that's a lot of times where those extender roles come in, staying connected, being able to be a place for the patient to ask questions.
Absolutely. And so is that where you see kind of the a building relationship between like the field of social work and the field of healthcare kind of emerging together with those extender roles?
Yeah, I think the word social work is such an umbrella term, and it can mean something different to everybody. So in my mind, when we're talking about social work, we're often, I joke sometimes, it's like, we got to figure out who's going to be this patient's cruise director, right? Like, is their cruise director through the land of church health? Do they really need a nurse because their leading issue is kind of complicated medical conditions? Do they need a health coach because it's chronic disease and basic behavior change? Do they need social work, connecting them to like medical social work, connecting them to different resources, getting them on SNAP, getting them on disability, getting them on Medicaid, connecting them to resources for housing and whatnot? Or do they need clinical social work? Do they need our behavioral health support? Our patients' lives are connected across all of those issues, right? But who should be that leading navigator with them, or the cruise director, to help them kind of navigate the waters? I say this like we've got it all figured out. We don't. I mean, this is hard to do, and trying to figure out the right number of humans. I mean, we got to pay the salaries for all of them too, so we have to balance all of that. But that is where I see the reality. Healthcare is being held responsible for health outcomes, but we know that our health outcomes are primarily impacted by the context of our patients' lives. So we have to have a way to address all of those things. And there's another concept that I really like when we talk about how these things intertwine, which is oftentimes it is easy to just talk about behavior change and choices that people make. And so you say life choices. And a lot of old public health are life choices. It's just based on education. It's like, wear sunscreen, wear your seatbelt, practice safe sex, take your medicine. It's very heavy on health education. Well, if all you do is health education, you actually make health disparities worse. Because the people who have the life context where they can then act on that education, do it. I need to eat more broccoli and walk more. I will buy more broccoli and I will walk in my neighborhood park, right? But the people who have a life context where they can receive the education, but they just can't act on it. They don't have the resources to act on it. They can't. They won't make those choices. And so then disparities can be worse. And so we have to be able to address what is creating this situation where the person cannot buy the broccoli that you're telling them to eat. Why and what do we do about that?
And what you just said echoes so much into, I mean, how the hub was built. Because a lot of what we do, yes, it's connection to resources. Yes, it's helping you manage all these different things in your life, but it's also providing you with the ability to even have the thought to do so. Like I worked on outreach and we actually went over to the Danny Thomas Bridge the other day. Um, and we're literally working with people that are on dialysis for cancer and they're sleeping under a bridge.
Right.
And the thought in my like that runs in my head is not only do you have to go through an excruciating, painful, mentally stressful, all these different really negative outcomes that you have to do when you're going through dialysis or if you're going through chemo, but then on top of that, you have nowhere to be. And the guy, word for word, said, "If I had any sort of income, do you really think I'd be under a bridge right now?" And that echoes across the work that we do. And I think it's just such an overlooked point. Exactly what you said. It creates disparity because people don't realize it's not someone's choice to not want to go pick up the broccoli or go walk more, do these things. They can't because they're focused on survival. They're focused on their next meal. They're focused on where can they lay their head tonight without getting kicked out by the police or have at least some resemblance of safety around them. And so I think the idea in the emergence of the relationship between healthcare and kind of like the mitigating of social determinants of health is huge. And I'm glad that it's, like I told you, I was doing research. I'm glad it's becoming a thought. At least from what I saw, it was like 2021, 2022 is kind of when people actually began looking into it from like a system standpoint. But I was talking to Dr. Sanders from the School of Public Health in Memphis. He was like, I've been researching this for 30 years.
Yeah, this is not new.
Yeah. I was like, I won't use the word angered me, but I was sitting there like, how does something that to me seems so simplistic in nature as far as like, of course these people have negative outcomes because they have no resources around them and they're in such almost insufferable points of their life. Like, how do we not see that connection or at least build it into the systematic approach of how we help an individual? What you just said echoes across the board. So I'm glad that that's, obviously it's a part of y'all's plan and it's what y'all do and have done since the genesis of the church health, but it really is beautiful to see and interact with just on our side of stuff because, you know, it really is impactful and the folks that we serve, especially the folks that have been experiencing homelessness for, 20, 30 years to be able to have a place where they can go. It also means the world to us too. So.
Well, one of the things that I learned from the pandemic or I observed from the pandemic that brought me a lot of hope, and I think it's something I continue to go back to, is that actually in Shelby County, we outperformed a lot of the other metro areas in Tennessee as far as our case rates and our testing rates and just our ability to come together and get things done. And it was pretty amazing to watch. I had an insider point of view, right? I was in the daily and then weekly meetings with the emergency management system. And in thinking about it, it's like, why are we able to come together on this so quickly, right? We were aligned across political parties. We were aligned across municipalities. We were aligned across industries. The hospital systems were all working together. I mean, what the normal kind of market competition might create or political competition might create was just not present. And it came down to a few things. Number one is everyone felt vulnerable, right? Everyone felt at risk. And everyone felt interconnected. So the health of the person bagging my groceries or the health of the person, living under the bridge is connected to my health, right? So we all felt vulnerable and we all felt interconnected. And there was a sense of urgency to act. If we don't do this now, it's going to get worse. And it pushed us through some hesitation. Now, it's also fair to say there's also resources. We had money, and when people felt like they had plenty of resources, we were able to share. When there was trust that there would be reimbursement for those resources, we were sharing in ways I've never seen us share before. And so I've taken from that a few things. One is, how do we create a sense of urgency, right? When it comes to any of the issues of poverty, providing education for every child in Memphis at a level that, takes them to whatever their career path is going to be, whatever they want to be, helps them set a vision for themselves. Or if it's related to housing, or if it's related to our justice system, whatever the institution is, healthcare, how do we create a sense of urgency that we don't have time to kick the can down the road for the next election cycle? We need to act now, and continue to lean into that interdependence. The quality of your child's education is directly linked to the quality of my child's education, and really believe in that. And I truly believe what we've demonstrated is where there's a will, there's a way.
Absolutely.
The other thing I think that it has taught me, and that I truly try to lean to, is to lead with a sense of abundance. And that can be hard to do in Memphis. Or maybe a sense of generosity is a little bit better to say. But I do believe, for the most part, there are enough resources to go around. And we know we can at least do it better than we're doing now if we share more. So what does that look like? How do we build that trust so people can share what they have for the better good of Memphis?
Yeah, absolutely. And I think the urgency is a great point to make. And I think I find it a lot through education, because the issues that we work with on a daily basis, we have an issue at least on the hub side with the social work sphere, of the amount of times I'll give someone a tour and they'll be like, I had no idea this was here. But it's because they don't have to interact with the issue or the experience of homelessness. And so they don't think, oh, I hope, like, I just know they all go somewhere. I know that they go to a shelter at night, but I don't have to really worry about it because it's not my problem. And so the interconnected part that you mentioned really is, I think, how we become to make meaningful change, at least in the relational side for service providers, because everything is connected at the end of the day. And like I tell people, like, the hub 590 couldn't be 590. We couldn't be what we've become without the amazing partners that we have, because at our core, we're a referral agency. Like, at our core, when you walk in that door, we either know something that we could refer you to, a resource we can connect you to, but if I don't, then I'm gonna do my best to find out, and then I'll see you tomorrow and I'll give you the answer. And I think that sort of generosity, as you said, with sharing resources, it's the current landscape of like how resources work. It's just, there's a lot of silos, and like, I've been to different parts of the country as I've done research for a few programs we're rolling out on the mental health side. And there definitely was like a different, I guess, style of conversation when it came to how they were addressing different issues, because there's a lot of different types of people in the room, and it was really cool to see. And part of that's why we're doing this podcast, is because not only to highlight the people and the passion behind the work, but also so people understand like what's available, and then what can you create from that, from a relational standpoint, from whoever you serve. And I think healthcare is one of those universal things where it doesn't matter who you are or who you serve or what you believe. Like, it matters. You need healthcare. You need the ability to trust that if something goes wrong or if you experience an emergency, you're able to not only receive that direct emergency care, but the post care, and be able to see a specialist. I mean, I see it on our side. Like, I have a gastrointestinal disorder, Crohn's, and I missed my ear follow-up. So I was like, I'll just call him and find out, it'll be good. He was like, I'm not free until September, or it was something of 2026. And I was like, oh, okay. And so you see it on the private side too. So I can't even imagine the amount of volume that y'all see and the amount of people that are in need that do not have insurance. So I think it all is going to kind of culminate together, and I share dreams of one day a community that all has we solve this, you solve that. We have a good reciprocal relationship, and I do think it's possible. And like you said, we've done it before when it came to COVID. Okay. Well, perfect. I'm going to ask the 3 fun questions now.
The 3 fun questions. Well, let me just add one thing before we go to the fun questions. I think I have a saying that we use a lot when we're trying to design a better way, and we're not exactly sure what it's going to be, but we know it needs to be better than how it is today. And I have been accused of being idealistic at times, but we joke about you have to believe that the pickle jar is in the refrigerator. And this is maybe a mom joke more than anything, but when your kids are asking you, well, Mom, where's the pickles in the refrigerator? And you're like, they're in the refrigerator. And I don't see them. And it's like they're blind to them because they truly just don't believe that the pickles are in the refrigerator. And I know the pickles are in the refrigerator. And I'm going to get in there and I'm going to go find that pickle jar. And that's kind of the mentality we have to have when doing this work. Whether you're working with an individual at the hub and you're like, I might not be able to find a solution for every issue, but I know there are some solutions out there. And so when we're doing this work to design better pathways for urology, let's say, we have to believe the pickle jar's in the refrigerator. Let's go find it, and kind of be tenacious about it. Believe in your fellow Memphians that people will be generous. Mm-hmm. And I think what we've tried to do is position ourselves as a trusted partner that maybe competitors that compete with each other for commercial payers and whatnot, they will trust us at Church Health to kind of navigate patients who need the care. We call it it's the art of the allocation of scarce resources, right? Who needs this the most? Let's prioritize who needs this care. We'll manage all the follow-up. We'll do, and we need you to do what only you can do, specialist volunteer. And so we've had a lot of success with that, and I think it actually could apply to other industries of just, the pickle jar. It's there. It is in the refrigerator.
It is there, and we know it. No, I agree 100%. And I think, I'm also a huge believer, like you said, idealistic. I wouldn't come to work if I didn't think I can make an ideal way that people can get these different issues solved. So I think that's the right attitude to have. Even if it seems a bit too optimistic or if it seems too far-fetched, I'd rather be chasing that than sitting here being like, well, this is what they gave us. So, here's this referral. Have a good day. Always improving, always finding better pathways. So I love that, and I agree. Okay. We'll start off with, I wanted to ask the job question, but I won't. Her job question. I wanted to throw it back to her and see what she would say. But we'll say you're stuck on a desert island. You find yourself with a DVD player, and let's just say it was a cruise went down. You're able to grab 3 movies. What 3 movies are you watching?
I do not have a good answer for this, but first of all, it'd have to be a VHS player because I'm going back to my middle school days. Fine. And I have to describe this for all the young people who don't know what a VHS player is, but I watched a movie called Revenge of the Nerds that came out. I saw it in the theaters. And then it came out on TBS. Growing up in Atlanta, we had TBS on public air TV. And so I recorded it on a VHS tape. And then I promise you, I watched that every Saturday morning. I don't know how many years. Easily 1,000 times, I guess. I don't know. Revenge of the Nerds. Okay. I would just throw it back to my middle school days.
Good. Yeah, you need some sort of feel good, this reminds me of a better time. I agree with that. I like that. That's a good. Okay.
It is not a high quality movie, and I don't recommend it.
All that matters is it brings you joy. You're the one on the island. That's all that matters.
It'll remind me of my childhood, I guess.
Mm-hmm. Do you have 2 others?
I'm not a movie connoisseur. No, okay. I probably would pick movies I've never seen before. I don't really like reading books twice or watching movies twice, except for Revenge of the Nerds. For some reason, that spoke to me.
Hey, nope, I agree. If you could snap your fingers and become an expert at any random skill.
This is easy. I would 100% want to be fluent in Spanish.
Nice. Yeah, I've had a few people have said language.
Yeah, I am on day 912 on Duolingo and terrible at speaking Spanish. So.
Yep. No, yeah. I think that's a very immersive skill and very needed too. So.
Yeah.
Okay, and then the final one, the daunting one. If you had to publish your autobiography today, what would the title be?
Okay, so this I've actually had this answer for a while. It's not an autobiography. It's a parenting advice book. Okay. And the title of it would be don't be too good at playing Barbie dolls. Right?
Oh,
And this was my parenting advice that I pass along to everyone is don't be good at doing something you hate to do. Because your kid will make you do it for hours on end and you will be miserable.
that's a good point.
So my strategy was to be the worst Barbie doll player ever. And I did not have to play Barbies.
Hey, that you said you're like, I don't know if it's a good. That was a great answer. That might get copyrighted. Yeah, you got to train them to think. I don't even want to play with them right now.
Yeah, don't come to me for playing Barbie dolls.
that was
So
perfect.
you need to be excellent with the things you actually enjoy doing.
Absolutely, that was perfect. Well, thank you so much for coming on. It really was a
Sure.
pleasure. And I appreciate all the work that y'all do. I can't imagine the day in and day out of, especially the position you have with operating all these different systems and all these different programs. So it's very appreciated. It's very needed. And I'm really looking forward to see where church health grows and gets all these new connections. And I'm really excited for Memphis in general. Like you said, I'd rather be optimistic. And so I'm choosing to hop on board with you.
Hop on the optimism train.
Absolutely. But thank you again.
Great. Thank you.